Hi, welcome. My name's David Fielding. I'm one of the organisers of the 2017 Global Health Conference, and it gives me great pleasure to introduce the final event of our conference, which is the 2017 McAuley Oration by Professor Mark McGillivray. So Mark's told me that his talk is going to last about 40 or 45 minutes, and then there'll be time for questions. But I assure people from the Infectious Disease Conference that we will finish on time, so don't worry. So I'm just going to say a few words about Professor McGillivray, whom I've known for the last 20 years or so. His hair hasn't changed colour quite as much as mine has in the last 20 years. Mark is from a small town called Koroit in rural Victoria. He is the son of dairy farmers, so he feels really at home here. But he left home at a young age and went to Melbourne, where he studied at La Trobe University and graduated from La Trobe with a PhD in economics. He has been an academic, mainly at RMIT and Deakin University in Melbourne, but he has also spent a large amount of time as a policymaker. Firstly, as the Deputy Director of the World Institute for Development Economics Research in Helsinki, which is a United Nations institution, and then secondly, for several years as Chief Economist of AusAid, which is the Australian International Development Ministry, the equivalent of NZAID. He has published very, very many publications on international development and foreign aid and its measurement. A very highly cited author within academia, but also a very respected policymaker who has worked with more governments than I can remember and international institutions. So he's been very influential the last couple of decades in the policymaking community as well as academia. And the topic of his talk tonight is very much part of his research agenda over the last couple of decades. Very much what he's about. So it's great to have him here. So I hope you'll welcome him warmly.
Let me thank Professor Fielding for that very nice introduction. On the grey hair, you might notice that my hair is quite short at the side, and I tend to get mine cut out. Yes, I'm delighted to be at this conference. I'm delighted to be here in Dunedin. Not only do I come from dairy farming stock, but with the surname like McGillivray, you might understand I'm also from Scottish stock. So coming to Dunedin and to Otago is an added delight for that reason. I've been very lucky. I've been here for 2 weeks. I've spent the last 2 days sitting through a wonderful conference with very high quality and very interesting presentations. I was fortunate enough to present an award to some local school children for some artwork they prepared for the conference. I haven't done a lot of that over the years, but I must say it was a delightful experience. I've also been lucky enough to spend 2 weeks in the Department of Economics at Otago with David and his colleagues, and that's been a very pleasant experience. David and I have known each other for quite some time, as he said. I'll add to that a bit. We were both at the University of Nottingham in the United Kingdom in 1994. That's when we met, in January 1994. David had not long come from a position at the University of Oxford to a position at the University of Nottingham. I'd come from Melbourne to Nottingham to take up a research fellowship there, and we've worked with each other, or we've kept in contact for those more than 20 years. David has helped me many, many times in the various capacities I've had. I hope that I can reciprocate in what I'm about to do tonight and to help him out. Now, the title of the oration is, as you can see, which developing countries are better at converting economic growth into better health and why? Okay. Now, I am an economist, I am an empirical economist, so I do tend to like to present numbers and graphs. So for the non-empiricists in the audience, I just do need to forewarn you of that, but I'll try and do it in a way that's not at least totally boring. But that is a warning. Okay. Okay, just let me give a bit of an outline of tonight's lecture. I'm actually going to present some work in progress, a research project in which I'm involved. It's in the fairly early stages of that project, that research, but nonetheless I'll give you some of the preliminary results that come out of it. But I want to put the research project in context. And the context is, I guess, a comment that I have on much of the research that empirical economists like myself do on links between economic growth and health. So I will do that. I'll then provide an outline of the research design of the project, which has the same title as tonight's lecture. What I'll then do is I will identify countries that punch above their weight in health achievement. And what I mean by that is countries that have higher levels of health achievement than we'd expect given their wealth, given their incomes per capita. Okay? So now the focus is not on countries so much that have high levels of health achievement, but it's on health achievement relative to what we'd expect given their incomes per capita. Okay, so that's a distinction I want to make. I'll make it a few more times as the lecture progresses. But there's an obvious question here of, why do this sort of research? And essentially, I mean, my concern is to inform policy choices aimed at better health promotion, but in particular to identify lessons that can be transferred to other countries, that can be transferred from the countries that punch above their weight to countries that do not. Okay. Let me start with a comment on economic growth and health and the research that focuses on that by people such as myself. Here I'm referring to cross-country research, okay? Comparing different experiences of countries using cross-country or international data. There's a large and growing empirical literature that looks at links between economic growth, or more generally achievement in incomes, and health in developing countries. The literature tests for a two-way or bidirectional or endogenous link between economic growth and health. The overall concern is whether better health contributes to higher economic growth and whether higher economic growth also contributes to better health, hence the two-way relationship to which I refer. Now, I have no problems with that research. It has led to many very important and very relevant, policy-relevant findings. But the focus, though, is primarily on economic growth. So we're concerned with whether better health translates into better economic growth. Okay? Often the concern is not so much in the other direction. In other words, we're concerned with the endogenous relationship so we can better understand and better quantify or provide the empirics of what drives economic growth in developing countries, but developed countries as well. But this is based on an implicit assumption that economic growth is a worthy end in its own right. It's based on the implicit assumption that economic growth is a worthy end or objective or achievement in its own right. I'd make another comment too, is that what we often do in academia is that we tend to stay in comfort zones, right? We tend to stay in areas that we already know quite a lot about. And what we do is we strive for small incremental steps or advances in those areas. Now, there's nothing inherently wrong with that, but I think what we should be doing is not sort of focusing on what we know or largely know, but trying to identify what we don't know and then basing our research around that. So let me just elaborate on this a little. Actually, I've gotten ahead of myself, but two comments, right? Research that's already made should commence by establishing what it is we do not know and framing further inquiry around that. And we need to be very clear about the importance or how to conceptualise economic growth. Okay, so just to repeat, we should start out by framing our research questions around what we don't know. And if we are looking at economic growth, then we need a very clear and grounded, explicit conceptualisation of economic growth itself. Now, I will expand upon these two comments in turn. Okay, so what we do know and what we don't know. Now, there's probably some empirical researchers that will validly and will rightly take me to task on some of these points, but nonetheless, I'm prepared to defend them. Okay. Look, higher incomes do, as a general rule, lead to better health. There's a number of channels through which that occurs. Higher private and public incomes can support increased expenditure on the provision of health services. I know also that the productivity of that expenditure is also very important. Higher incomes can also contribute to known drivers of health, such as education levels and the provision of water and sanitation services, which matter in developing countries. Now, I know there are many other channels and there are many other aspects of the linkage. Here I'm just singling out some examples. So what I would say is, let's just accept that, right? Let's accept there's a relationship there. Let's accept that higher rates of economic growth and higher levels of per capita income matter for health achievement. What we do not know, or know less about, is why some developing countries have higher health achievements than would be expected given their income levels and vice versa. To me, that is an unanswered question. To me, that is what we don't know enough about, and I want to frame my research around that question. I would add that this is presumably a story about, one, why growth is more pro-health in some countries than others, and two, or two, non-income drivers of health achievement in these countries. I mean, we should be important. I mean, we need to acknowledge that there are many, many other drivers, of which health is merely one, which economic growth is merely one. Now, something a little more fundamental. Now, those of you that were at the two-day conference to which David and I referred will have had the pleasure, the great pleasure of receiving a presentation from Associate Professor Stephen Knowles. He was looking at he was looking at me quizzically there. I can see him in the audience, and now he's smiling. But anyway, and I do not exaggerate. That he focused on the Sustainable Development Goals, a new initiative coming from the UN and applicable to all countries. Those of you that know, they replace the Millennium Development Goals. And Stephen made some quite similar points to what I'm about to make. I run them a slightly different way. I rely here on the philosophical literature regarding instrumental versus intrinsic properties of various outcomes. Okay, but what I'm about to say is reinforcing of what Stephen said 2 days ago. I might add that we did not collaborate at all. I saw his presentation for the first time of the morning of the conference, and he's seeing my presentation for the first time now. So this was quite coincidental. But I think, though, the point I'm making here, though, is that among economists such as Stephen and also David Fielding that focus on developing countries, we are much more attuned to the fact that there are some huge challenges, and among them include achieving higher rates or higher levels of better health. And to that extent, we see economic growth as within that context. Let me just explain a bit more. Economic growth, by definition, is the expansion of per capita income levels or average income levels in countries, or the expansion of wealth. I know wealth can also take into account assets, but I think it's as an approximation I can refer to income as wealth. The central point, though, is that income has no intrinsic value. it has no intrinsic value or little intrinsic value. A fistful of dollars in itself does nothing for you. It's what you can do with the fistful of dollars that is important, okay? That's a fundamental distinction. You might argue that having a fistful of dollars or having high income might be important because it gives you a sense of economic security. I mean, I'll concede that, right? But I think other than that, income has no intrinsic value. Its purpose is largely instrumental, okay? And here, and I've lost some formatting in the quote, but people like myself trot this quote out all the time, but it has resonance, and I see no reason why I shouldn't continue to use it in events like this, but also in papers and books that I've produced. Aristotle said that wealth is evidently not the good we are seeking, for it is merely useful for the sake of something else, okay? So that, my take on Aristotle, and other people's take on Aristotle's comment, is that income has little, if any, intrinsic value. Its use is, or its purpose or its value is largely instrumental. Now, the something else, and here I run a line that has been presented in work within the United Nations. Many of you will be aware of the United Nations Development Programme and the Human Development Report that it publishes annually. And it's around the human aspects of development. So the something else is the opportunity of people to realise their potential as human beings. This requires many things, but it certainly requires better health, which is both of intrinsic and instrumental value. Okay. To me, this is the justification for the research that I'm undertaking, and it provides a conceptual context for what's about to follow. But back to sort of completing my two comments on literature. Again, the literature on economic growth and health or human capital has produced many, many important insights. But given the very nature of growth, let's focus more on what growth drives and relatively less on what drives growth, okay? In a developing country context, I think that is of fundamental importance. So at the risk of overstating it, let's focus more on what growth drives and relatively less on what drives growth. Now, that's the background, okay? That's the context, right? Now let me talk about the research project. It asks which developing countries punch above their weight with respect to health achievement. I've already defined punching above their weight, but there are two aspects to that to reiterate. The first is which countries are better at converting economic growth into better health. The second aspect is which countries have higher levels of health than predicted by their incomes per capita. So if you like, incomes per capita, income or wealth is the weight, okay, the punch is the achievement in health. Now, I employ mixed methods in my research. Now, for me, that's quite it. David's looking at me in a quizzical way now. David knows that my training is essentially as an applied econometrician. I've spent a reasonable amount of time, 20 years, to use the phrase, running regressions, basically. So doing econometric analysis, trying to fit data together. Nothing wrong with that, but I think that research is part of a story. If we really want to really dig deeply to get insights that we can't get from robust and scientific analysis of data, we do need to use mixed methods research, and we do need to back up our empirical research with such things as what was qualitative research, key informant interviews, focus groups, that sort of thing, okay? Now, I'm still learning, okay? I've forgotten a lot about econometrics, but to me, this is something that I rely on my collaboration with other people for this research. But something that David mentioned, I've spent a bit of time both in academia and outside of academia. I think I think I'm probably talking to the economists here more than any others. So I think people outside of economics will accept the points I'm making. That really, if you want to convince policymakers to change actions or to help them design programs, to take your advice, to present econometric results in itself doesn't achieve much, right? You could say it has little intrinsic value. So, okay, you really do need to dig more deeply and validate your findings from empirical research with the qualitative research, or at least conduct those two methods of research in mutually complementary ways. So that's what we're about. So what we do is we use empirical analysis to select country case studies. Okay, so we use the statistics to identify those countries that seem to punch most above their weight, and then to dig down more deeply to understand that, we use a mix of empirical research, so further econometric testing, but key informant interviews, focus groups, and other means of qualitative investigation. Now, I did warn you, I am an empiricist, I can't help but, give some statistics and talk a bit about data. So what you're seeing tonight, the rest of the lecture, is more about the empirics, with a little bit at the end of some qualitative research. So what we're about to embark upon now is an answer to the question, which countries have higher levels of health than predicted by their incomes per capita? And I also, as an empirical researcher, and for the non-empiricist, you have to indulge me here for a few minutes, okay? I feel as if I have to say something about data. Basically what I do is, for the purpose of tonight's presentation, in the project we look at many, many more other indicators of health, and probably more incisive ones than the first one I'm looking at, okay? But the two indicators I look at tonight are life expectancy at birth in years. I take an average for the period 1990 to 2015. I know, one of the principal criticisms of life expectancy is it says nothing about the quality of life years. I accept that. And that will be addressed in further work. I'm much happier with using the child mortality rate. So the number of children not reaching their fifth birthday per 1,000 live births, and I use the average for the period 1990 to 2015. Income per capita as a standard measure, I use gross national income per capita adjusted for purchasing power parity. The sample of countries that I look at are 138 developing countries. Now, I want to have a reasonably large sample of countries, so there are many countries that some people think shouldn't be considered developing, but I basically take the UNDP's very high human development category. For those of you that know about this, the UNDP publishes the Human Development Index, which combines income, education and health into a single number, and it uses the levels of that index to define countries. A very high human development category country is one with a human development index of 0.8 or higher. The index varies theoretically between 0 and 100. Now, what that does is, of the about 180 countries for which data are available, that excludes 41 countries. Okay, so I've taken 41 countries out of the sample, considering them to be developed, and the rest developing. And all data are taken from the Human Development Report database. Now, okay, so here I might need a little more indulgence. Okay. The question here is, how is punching above weight detected? So what I have is, I have income, GNI per capita, on the horizontal axis, and I have life expectancy on the vertical axis. Each of those dots represents a combination. It represents, that represents a country. So there are 138 dots there, okay? And they show combinations of, they show each country's GNI per capita, its income, charted against its life expectancy. So the countries up the top right-hand corner, those dots, each dot's a country, okay, have high incomes per capita and high life expectancies. Those down the bottom are the reverse, low incomes per capita and low life expectancies. Okay, so that's where I start. What I do is I compare a cross-country experience or profile of income per capita charted against life expectancy for each of the 138 countries. Okay, that's the first stage. Then what I do is I use a simple empirical technique, a curve fitting technique, is I fit a line of best fit, okay, to the data. Now this line of best fit, in a sort of non-technical way, basically captures best the relationship across the countries between income per capita and life expectancy, right? So as you'll see, okay, we've got, as income per capita increases across countries, so too does life expectancy. So countries with higher per capita incomes have higher life expectancies and vice versa. Okay, that's the next step. So it sort of confirms that there's a simple relationship between income per capita and life expectancy, right? But the key point, though, is you'll note that, again, recalling that each of those dots is a country, okay? That some countries lie above the line and some countries lie below the line. Now, the line is actually it's the prediction. It represents, based on this cross-country experience, the level of life expectancy that would be predicted by income per capita. Right. Now, the fact that you have some countries above the line says that they have higher income per capitas, higher life expectancies than predicted by income per capita. And you have countries below the line have lower life expectancies than predicted by their incomes per capita. So the countries above that line punch above their weight. The countries below that line punch above their weight, emphasising the line is actually the prediction. That line is the predicted level of life expectancy based on a simple relationship with income per capita measured by GNI. Now, someone would be saying, what about other drivers of life expectancy? Yeah, fine, but I'll get to that. Okay. Now, so what I'd like you to imagine then is if you can imagine the vertical distance between each dot and that line. That vertical distance, in other words, the extent to which a country lies below the line and the extent to which a country lies above the line, is my measure of under and over achievement. For the statisticians in the audience, what I'm doing is I'm running a simple least squares regression and I'm taking the error terms. Those error terms, the vertical distance between the line of best fit and each point, that's my measure of under or overachievement. Okay, I've sort of said all that, haven't I? Okay, I tend to do this sometimes in presentations. I get a little bit ahead of myself, but anyway, so what is on the screen is pretty much just what I just said, okay? Now, but I want to focus on the last few points in this screen, okay? Why will some countries be above the line? Well, it'll be due to the nature of economic growth, recognising that economic growth is a growth of average incomes per capita. Some will lie above the line because of the nature of growth in those countries. The nature of growth will be inherently pro-health promotion, and there can be many, many reasons for that. Referring back to my comments on endogeneity, and I'll say this quickly for the econometricians in the audience, could simply reflect strong feedback loops between economic growth and health in a way, though, that sees a given increase in health leading to a bigger increase in growth, leading to a bigger increase in health. But it can also be due to other drivers of health achievement. I mean, if we go back to I hope this will work, the position of those dots, the position of each country, won't only reflect the extent to which economic growth translates into better health, it will also reflect other drivers of life expectancy, in this case, other than economic growth itself. Now, just come back to this. This is the graph I just showed you a moment ago. I just want to highlight one point here. This is R is it's a correlation coefficient. Basically, it says that 72% of the variation in life expectancy is predicted by the log of income per capita. Okay, so now what I've got is I have the top 20 achievers. So these are the countries. Now remember, each of those dots before, is a country. Okay? So I've just taken out those that lie furthest above the line of best fit. They're my high achievers. Okay? I'll just let you just absorb this for a moment, but okay, years here is not the years of life expectancy, as you can probably imagine. It's overachievement. Okay, so Cuba. What this says is that based on its income per capita, average incomes in Cuba, and also taking into account the cross-country relationship between income per capita and life expectancy, Cubans live 12.2 years longer than we'd expect, given their income per capita. Now, this is an average figure. They have lived an average of 12.2 years longer over the period 1990 to 2015. Okay. Vietnam comes in second. Vietnamese have lived almost 12 years longer than we'd expect based on their income per capita. We have some countries from the region. Vanuatu, Solomon Islands, and Tonga. I just ask you to remember that, because I want to come back to this. You might be looking at the Syrian Arab Republic, Syria. My data stopped in 2015. Okay, and we'll know what's happening in Syria at the moment. So I'm not capturing that. Also, too, remember, I'm taking an average over 16 years as well. Okay, so Vietnam, China, quite a mix of countries. Cuba is one that it's not a surprise. There's been similar research that has been done looking at multi-dimensional well-being achievement, taking into account a range of indicators. Cuba does well in multi-dimensional well-being achievement relative to its income per capita. Now, we go to the other end of the scale. These are the low achievers that have lower levels of life expectancy than predicted by their incomes per capita. So at the very bottom, we see Angola and Equatorial Guinea. So based on its income per capita, we would expect people in Equatorial Guinea to have lived 20 years longer than they have on average between 1990 and 2015. Okay? Angola 17.4. What is it about this list of countries? Well, the first thing that you will notice is that, yes, it is all of them, are all from Sub-Saharan Africa. Okay. Now, you might say, okay, well, Sub-Saharan African countries have low levels of income per capita, they're poor. Okay, but that's what this is saying, is that even by the levels of their income per capita, they have much lower health and life expectancy than we'd predict. So it's just not a story. It's not a story about low incomes. It's a story about the conversion of those incomes into life expectancy and other drivers of life expectancy other than income per capita. Let me now turn to child mortality. I do the same exercise for child mortality. Now, this time the line goes down, okay? So higher incomes are associated with lower child mortality. Lower incomes are associated with higher child mortality. Now, that dot right up the top, again, represents a country. Any guesses? I'll keep you in suspense. Okay, so above the line this time is bad, okay? Above the line is bad. So it's higher child mortality than predicted by income per capita. So countries want to be below the line, okay? Okay, so here we go. So we're going to go with the high achievers, those below the line, with lower child mortality rates than we'd expect given their incomes per capita. Now, what do you see? We see 20 countries, okay? Solomon Islands. So based on average data between 1990 and 2015, each year, 66 fewer children have died before their fifth birthday in Solomon Islands than we would expect given its income per capita. 66 fewer children have died before their fifth birthday. Fewer children have died before their fifth birthday in Solomon Islands than would be predicted based upon their income per capita, its income per capita. Vanuatu was back. Recall it was in the previous list. Vietnam is still there. Tonga is there. Samoa is in the list. Syria is again in the list, but again, I make the previous comment, we're up to 2014. The previous list was reasonably diverse, but nonetheless, China is also back. Now we go to the low achievers. Now remember I asked you which was the country right at the top. Okay, we're about to see. Now, this is not a good news story, clearly, okay? It's of interest, but, you know. Which of the two countries at the bottom of the list before? Equatorial Guinea and Angola. Okay, now, Associate Professor Knowles made a comment about these two countries in his presentation 2 days ago. He observed that they were natural resource-rich countries, okay? Equatorial Guinea in particular has had over recent years a spectacular increase in its income, owing to oil wealth, if my memory is correct. But the nature of social structures in Equatorial Guinea is that oil wealth is concentrated in relatively few hands, and there's been virtually no or negligible improvement in other conditions. So, you know, I use the term loosely. There's been no sort of trickle down. You know, that wealth hasn't been dispersed across the population base. So basically, if you ignored Equatorial Guinea's income per capita, I can't remember what it is, but it's around $20,000. Okay, so and this is purchasing power parity adjustment. So it sort of puts it up with, you know, with developed countries. If you just ignore its income per capita and just look at its health education indicators, it's a very poor country. So what's happened is that there hasn't been the conversion of that increased wealth into more broad-based living standards. Similar story about Angola. We also look, though, you look at the countries on the list. Sub-Saharan Africa, again, dominates. But of these countries, we have many that are rich in natural resources. Angola, Equatorial Guinea, Sierra Leone to a certain extent with its diamond wealth, South Sudan, Nigeria, Oman appears there, the oil-rich Middle Eastern country. Czech Republic is an interesting one. I haven't got an interpretation of that. I want to have a look more closely at the numbers. Okay, that could be a statistical anomaly. But nonetheless, though, it's an interesting picture. But of course, you might have noticed this. Now, okay, I made a mistake in my empirical work. what I did was I started out with a list of just developed countries, and I thought I took out all of a list of developed and developing countries. So a list of the world, basically, for which data were available. I went through and I thought I took out all of the developed countries. But I hadn't, as it turned out. And I only noticed a few days ago when I was preparing this lecture. I inadvertently left the United States in the sample. Now, this is not, I'm not trying to bash the US in any way, but it turns out, though, that the US is, if we just said it's a developing country, if we just keep it in the list, the US is actually in the lowest achievers. So basically, based on the US's average income, or its income per capita, from 1990 to 2015, we would expect each year 30 more children to have lived until their 5th birthdays. So I think that's an interesting finding. I sort of do know where I am. I am in New Zealand. If I was to put New Zealand into the sample, it would be in the higher achievers. I've done a similar paper based on, it's a multi-dimensional well-being paper, and it's I take the Human Development Index, so a combination of income, health, and education, and I do the same exercise for it. New Zealand, based on 2015 data, ranks number 6 in the world. So in the conversion of income per capita into multi-dimensional well-being. But I'll mention that in passing. But I thought I'd just present this result for the US. It is an interesting one. There'll be many interpretations of this. All I would say is that there's a huge amount of diversity within the US, as we know. So I don't know how I'm going for time, but okay, now what I do is I say we take those countries that are in both lists, all right? Now, obviously, I'm going to, with the project to which I refer, I'm going to do a lot more of this work. But just based on life expectancy and child mortality, which countries are in both lists of those punching well above their weight? And this is the list. Solomon Islands, to name a few. Vietnam, Tonga, Vanuatu, from the region. So the ones I would emphasise here are Solomon Islands, Vietnam, Tonga, and Vanuatu. And here I'm about to go a little further, but I am speculating here. I'll come back to the screen, but what is it about these countries that places them in the highest achieving category for both indicators of health? Has economic growth in them being pro-health achievement? I'll explain what I mean by that in a moment. Have factors other than income per capita driven their health achievements? Or is it a combination of both of these factors? Now, this is the question that our project will look at in more detail. And I hope to come back to another health conference here, David, to present the findings, okay? Hopefully next year, but who knows, Now, so with these framing questions in mind, let's just go back to the list, okay? So, now, I haven't got the answers. I mean, I've just got the questions at the moment, okay? But is it primarily the nature of economic growth, higher income achievement, that deems these countries high achievers? Or is it factors other than economic growth that have driven this achievement? Or a combination of the both? Now, I'll comment on, I spent a lot of time in Vietnam. I've spent a lot of time in Vanuatu doing various evaluations. And I've made a couple of trips in my capacity with AusAid to the Solomon Islands. So I am across some qualitative research on conditions in those countries, but I'm emphasising, I'm just thinking aloud now, okay? I haven't got any definitive answers, I've just got some thoughts. What I would say about Vietnam is that Vietnam has a tremendous achievement of pro-poor economic growth. If we look at most of the countries in the world, if you look at East Asia, we tend to talk about the tremendous achievements of China. that it has pulled more people above the income poverty line than any other country. If you look more closely, though, Vietnam's record is more impressive. It hasn't pulled as many people out of poverty as China, but it's pulled a greater proportion of its population out of poverty than China has. And much of that has been about, putting last first. It's been a focus around the rural poor, aimed at improving production, providing reforms to markets, but it has had, though, Vietnam has had quite a pro-poor orientation to its growth. Okay. Now, we're talking income poverty, but I think as a stylised fact, we would expect poor families, those living in poverty, to experience higher rates of child mortality. So my interpretation of Vietnam's experience is this focus on the very poor, putting the last first, and seeking to improve income levels has flowed through into improvements in health. So in Vietnam's case, I'll argue that I will assert, it is largely a story of the nature of growth in Vietnam, which has been pro-health promotion in its orientation. But I'll stand corrected on that. I'm willing to, I will hear questions of it. Vanuatu and the Solomon Islands, two characteristics or a characteristic that both countries share is, there's a very high proportion of the populations in both countries living in the informal sector and with access to land and access to relatively fertile land that provides a basis for food production. Okay, so now of course I know that food per se does not guarantee better health, but I will assert that this is worth looking into a little more. I would suggest the communal land access has been important in driving the overachievement of Vanuatu and the Solomon Islands. Both, of course, are very poor countries and remain so in the bottom sort of quartile of countries worldwide in terms of per capita income levels. But they do certainly punch above their weight, and I'm suggesting one of those factors is access to fertile land. Tonga I cannot talk so much about, but that is my initial interpretation. But again, what we need to do in our project is to actually dig much deeper into these countries with the sort of qualitative research to which I referred before. Okay. Solomon Islands, like Vanuatu, very high. Well, people have access to land. They have access to fertile land. And my contention or my assertion is that that has been an important factor in driving overachievement in health in those two countries. So I think I'll conclude with a stay tuned, and I will thank you very much for your attention.
So we do have a few minutes for questions. Jackie, do you have the microphone? Unfortunately, we apologise, we just have the one microphone, so Jackie's going to have to sprint up and down. But we have one question at the front here.
Thank you very much for an interesting talk. If you weighted each of those points by the Gini coefficient for each country, what would happen to the outcome?
Yeah, okay, that's a very good point. In trying to get a little closer to the question about, overachievement in terms of economic growth, we need to control for other factors. That's what we're doing at the moment. My prior is that the Gini coefficient or some other, noting there are many measures of income inequality, but the question is, does income inequality or income equality matter? Hence the reference to Gini coefficient. I would say almost certainly so. Vietnam has relatively low income inequality. It has risen a bit in recent years. We lack data for the Solomon Islands and Vanuatu, but the impression is that in both, income inequality levels are quite low. but that is certainly one of the control variables that we're using in looking at factors other than economic growth that have contributed to overachievement and underachievement. If you take what I said about Equatorial Guinea, I was basically saying it is societal inequality that has meant that Equatorial Guinea has not been able to translate its spectacularly high recent income achievement into broad-based improvements, including those in health. So, short answer is absolutely. Yep.
Just a preliminary follow-up question, I guess, to that would be,
Yep.
perhaps a starting point might be to look at the average Gini coefficient in the high achievers versus the lower. Is that something you've looked at?
I'm sorry, can you say that again?
Look at the average Gini coefficient in the high achievers versus the low, just as a sort of hypothesis-generating exercise.
Yeah, that's a good comment. What we'll do though is, I've got a database set up, and one of the issues about the Gini and other measures of income inequality is that I'm not going to be able to get comparable inequality measures for 138 countries. Okay. So, but what I could do is to get an idea of what's going on is to do exactly as you say, okay. But to more precisely control, to net out the potential impact of inequality on health achievement, we need we need cross-country data for it. But yeah, that would be a very useful starting point. I agree.
Just a comment, I guess, about the low achievers. I just wonder what the impact of the HIV epidemic in those countries is on the mortality.
Okay, another excellent point. Okay, what I did was I repeated the analysis for life expectancy using data from 2010 to 2015. So sort of post-HIV/AIDS pandemic. Now, I know there's lingering impact still, but I was trying to get a sense to which the HIV/AIDS pandemic has sort of knocked countries off an equilibrium with income per capita. And the answer is pretty much the same results. You still get sub-Saharan African countries dominating the low achieving rates. But it's a very good point. And
I noticed that a lot of the sub-Saharan African countries are doing very poorly. They've also had a lot of civil war and governments that have not been stable. And I suspect there are lots of reasons for that, besides the fact that they're African.
I emphasise it's not that they're African. It's the characteristics or the realities that those countries face. But the point is this, though. It's a good point. I've been anticipating this. That's why I've got this piece of paper in my hand. The question here is, if we really wish to net out the impact of variables other than economic growth or income achievement on health achievement, then what would those variables be? And conflict is an obvious one. But I note, though, with conflict, conflict will lower both income per capita and it will lower health achievement. Okay? So it might not alter over or underachievement as I'm presenting here tonight, but it's certainly a factor that if I was to, and maybe anticipating some other questions, if I had a list of control variables, okay, to try and separate non-growth or non-income factors, what would they be? And some of these are related, but public expenditure on health, which data are available, some data are available on private expenditure on health, the productivity of those expenditures, access to water and sanitation. And this is a list people in the audience are not going to be surprised by what I'm about to say, but I'm looking at cross-country comparisons. Conflicts, the prevalence of natural disasters, levels of governance, which would include political stability. Note that Zimbabwe was one of the low-achieving countries and what's happening in Zimbabwe right now. and education levels. So, you know, I've got a list of sort of 10 variables that I would look to and try to explain cross-country differences other than income per capita. I know there's a lot of other variables, but keep in mind, my focus here is on cross-country. So I am slightly constrained, well, I'm totally constrained by availability of data, and that reflects really the list I've just identified.
Hi. Are you going to look at the change in income and the change in health status over that 25-year period?
Yeah, I've got another set of results that looks at rather than the level of income per capita, it's the change in income per capita, so it's growth, and I compare that to changes in the health variables as well. Now, I can't give you many insights as the result of that, but that's part of what I consider sort of robustness testing, is when we can look at these variables in different ways, and we need to look at levels as well as changes over time. So, short answer, yes, but I can't give you much more than that at this stage. So, but another very good point, thank you.
Just another question about looking over time. Is there an opportunity to look at some of those hypotheses on impact by looking at changes over time? So where you know places like South Sudan, where there's been conflicts and instability, where prior to that there was more stability, or where there's been natural disaster, where you can look at a country and see what happens when you have a sudden impact, or the HIV epidemic would be another thing where you could look at the onset and see before and after.
Yeah, exactly. Yeah. I take that as a comment, and I
Another readily accessible source of data that hasn't been mentioned yet, you mentioned water and sanitation, but the expanded program on immunisation has also been present during this period, and measles in particular, and to some extent whooping cough and so on, you know, have been major changes over this period. And of course it is something which is varied between countries. So is that a variable which you are thinking of looking at?
Yeah, I said 10, I read out 9. So that was the other variable. So yes. Yeah. I'm not so sure about cross-country data availability, but the sufficient availability, I would assume. I wouldn't get data for 138 countries, but at least 100, I would suggest.
I mean, there's debate about how good the data is for some of the countries, but it's available for all of them, and also because it's quite a long time period, as you indicated, there would be much greater discrepancies in the first part of the time period you're looking at than perhaps in the later part.
Yeah, I acknowledge that I lose a lot of richness in the data set by taking that average. So, and we're addressing that. I might also add too, you know, that people like David and I and Stephen who work using developing country data sets have learned to live with data measurement errors. I would just add on methodological grounds as you know, well, if those errors tend to be purely random, we've got ways of addressing that. But if it's non-random, then we're in trouble, and we've got to take, you know, a reasonable degree of scepticism about our numbers, but that's where our qualitative research comes into play. And again, I take that as an argument for looking at mixed methods approaches in our research.
So can I just intervene? Yeah. I'm conscious that we shouldn't trespass too much on infectious diseases time. So I do apologise, but I think there's time for just one more question, but Mark will be around for a few minutes afterwards. So if you do have a question, please do feel free to come up and talk to him, but we'll just have one microphone question now.
Yeah, is there a way of categorising the way that health systems are organised, you know, universal health access versus other models, for example, to see if that has a bearing?
My very honest answer is I'm not sure, but I do understand the point you're making, and I think we would like to address that in our search for additional data. But, yeah. Can I also say I'm just delighted that you know, as an empiricist that presents scatter plots, I'm often sort of worried that when I come into mixed audiences that I'm going to send everyone asleep. Now, I may have come close to that at times, but the fact that you're still awake and asking me questions, I must thank you for that.
Thank you again indeed to Professor McGillivray for such a stimulating talk. We do have a small presentation. Now, as it happens, one of our students who won the prize for the best poster presentation this afternoon, also quite coincidentally, before he learned that he won the prize, was lined up to present the gift to Mark. So, Jonathan, could you come forward now, please? And we also have a photograph.